Let's continue with the descending tracts. I already showed you this picture as well. Here we repeat that basically there are somatomotor and visceromotor pathways. The visceromotor I'm not going to touch today because this is going to be discussed in detail when you talk about the autonomic nervous system. We are going to focus on the pyramidal and extrapyramidal tracts, which go through or start or begin in the brainstem, just like when we discussed the spinal cord pathways. So just like the ascending tracts, you can see that we can group the tracts into pathways that go through the brainstem, end or begin in the brainstem. But more important is according to the different functions. So I'm going to start with the pyramidal tract. Here, when we say pyramidal, we mean both those fibers that go down to the spinal cord, this is the corticospinal tract, or those which end in the brainstem, in the brainstem motor nuclei. These motor nuclei are the trigeminal, the facial, glossopharyngeal, vagus, and the hypoglossal nuclei, which respectively innervate the muscles of mastication, facial expression, larynx, pharynx, and tongue. These obviously need a supranuclear innervation too, and this is the corticonuclear tract, or also called corticobulbar tract. So here I'm going to show you the corticospinal tract first, that goes through the brainstem in the mesencephalon, in the middle of the peduncle. Then in the pons, the fibers are scattered and form more like a loose corticospinal tract. They become compact again in the medulla of the pyramid, in the medullary pyramids, and then there is the medullary, the pyramidal decussation in the medulla, the lower level of the medulla, and then we have the lateral and anterior corticospinal tract. The lateral is obviously going in the lateral funicle of the spinal cord. These are the fibers that already cross at the level of the medulla, and the anterior tract is the one that is not crossed at the level of the medulla, only crosses at the level of the innervation. So this we have already discussed, the spinal cord part, and now we're going to focus on the corticonuclear tract, which goes to the motor nuclei of the brainstem. This picture shows that most motor nuclei have bilateral innervation. Bilateral innervation. So it's like evolutionarily the face is over-secured, that it's going to get innervation. So the descending pathway here, you can see, gives innervation to both sides. And this is very important clinically, because if one side is lesioned, the muscle is still going to be intact because it receives innervation from the other side too. Except, and here you can see the exceptions, and this is something you have to know. So, except the lower muscles innervated by the facial nerve, except the genioglossus muscle innervated by the hypoglossal nerve, and the uvulary muscle innervated by the vagus. This receives innervation only from the other side. And the lesions can be supranuclear or peripheral lesion. This I already mentioned that the spinal cord lectures when the upper motor neuron or the lower motor neuron is lesioned. So let's see first the facial nerve palsy, which is a must know. So this is going to be asked in the exam. You have to know the difference between peripheral and central facial nerve palsy, facial nerve lesion. So as you see in this very simple example, this is the facial nerve nucleus. Inside this nucleus, the different motor neurons going to different muscles are differently positioned. So you can see that the upper muscles have bilateral innervation. The lower muscles have only unilateral innervation coming from the other side. So, you can simplify it. Muscles around the eye and forehead have bilateral innervation. Muscles around the mouth have unilateral innervation. Why is this clinically very important? If we have a central lesion here, for example, in the internal capsule, descending fibers of the corticonuclear tract are lesioned, then you can see that only the muscles around the mouth and the lower eyelid will be paralyzed, because the muscles of the forehead and eye get bilateral innervation, so it still has an innervation, this part of the nucleus. In peripheral lesion, if the nerve itself or the whole nucleus is damaged, obviously those muscles will be paralyzed. Here you can see another picture basically showing the same thing. If we have central lesion, once more, only the lower muscles are affected, and on the contralateral side. If you have a peripheral lesion, like in this case, there is a tumor, acoustic neuronoma, and then half of the face is basically lesioned on the same side. All the muscles are affected. And plus, at the end of the semester, so for the exam, you will learn other functions of the facial nerve, and you will have to list all the lesions, all the signs of the facial nerve palsy. You already know taste, that through the chorda tympani, facial nerve is involved in taste, anterior 2/3 of the tongue, and of course this will be lost too. And many times this is the first symptom, first sign of a facial nerve palsy. Why? Because these are sensory fibers, and these are very thin fibers. The myelin sheath is much thinner than of the motor nerves, which have very thick myelin sheath. So many times this is what the patients first notice, that they cannot taste the food. Then this is something you don't know yet, but we will do this when we do the ear. The hyperacusis is a symptom, which means that you are too sensitive to loud noises. And this is because the facial nerve also innervates the stapedius muscle, responsible for the stapedius reflex, which is a reflex that protects our inner ear against very loud noises. And this, you already learned it a little bit, but when we do the eye, you will hear it again, that through the greater petrosal nerve, which is also a branch of the facial nerve also innervates the lacrimal gland, so is responsible for tear production. So this is all lost in facial nerve palsy. And these are very important when we look at the peripheral lesion, when the patients cannot close the eye. It's very important. Many times this is mixed up in the exam too. So facial nerve innervates the orbicularis oculi muscle, which closes the eye. So if this is lesioned, of course the patient is not able to close the eye. And then this, together with the previously discussed decreased tear production, is a very bad thing for the eye. The eye can easily dry out. Here you can see that on this side, this patient has lost all muscle activity. In contrast, in the central lesion, the patient is still able to wrinkle the forehead and can close the eye, which is very important functionally. The other such nerve which receives unilateral innervation, supranuclear innervation, is the uvulary muscle innervated by the vagus nerve. Here you can see that it's diagnostically important, because when you look into the patient's throat, you can see the asymmetry of the uvula and the soft palate. So it has a diagnostic importance. Not so much the loss of the uvulary muscle is important, but the diagnostic importance. And the third such nerve that has only unilateral innervation, supranuclear innervation, is the genioglossus muscle, which is innervated by the hypoglossal nerve. And in these examples, you can also see that the tongue is moved to one side. The genioglossus muscle is responsible for sticking the tongue out. So you stick the tongue out, and on one side it's paralyzed, then the normal genioglossus will pull the tongue to that side. And if it is present for long term, you can see that there is atrophy of the muscles too. Finally, let's see the brainstem reflexes. And just with the spinal cord, just like with the spinal cord reflexes, we have monosynaptic reflex here too, which is basically the proprioceptive reflex of the mastication muscles. The best known example is the masseteric reflex, because this is the one that neurologists also examine. And just like with the spinal cord reflexes, you will have to be able to list the parts of the reflex, starting with the receptor, then the efferent nerve, then the central connections, the efferent pathway, and finally the effector. So here, in this case, the receptor is obviously, just like with any other proprioceptive reflex, the masseteric muscle, spindle of the masseteric muscle. And then the afferent nerve is the trigeminal nerve, the mandibular branch, and that goes to the mesencephalic nucleus of the trigeminal nerve. Remember that it is like a ganglion positioned in the central nervous system. It has pseudo-unipolar nerve cell bodies, and the central process goes to the pontine nucleus or principal nucleus the motor nucleus in the pons, motor nucleus of the trigeminal nerve, and then the monosynaptic reflex is closed. And obviously the efferent is also going with the trigeminal nerve, the motor branch, to the muscle. So this is the monosynaptic reflex of the brainstem. And there are many polysynaptic reflexes in the brainstem. These we already talked about when we did the reticular formation, all the reflexes with the respiratory, cardiac centers, cardiovascular centers, vomiting, coughing, swallowing. These are all brainstem polysynaptic reflexes. And the last group of reflexes are the facial reflexes, when the facial nerve is involved, closing the eye is involved. Corneal reflex is something that neurologists again examine. Here the afferent is obviously the sensory nerve, so the ophthalmic branch of the trigeminal nerve. You touch the cornea, which is very sensitive, and the response is eye closure. Or everybody knows if you go outside or suddenly light is shining in your eyes, you close your eye. In this case, the afferent is obviously the light information through the optic nerve, and then in both cases, facial nerve is the efferent part. And then we have a reflectory closing of the eye, orbicularis oculi muscle. If the light is not that strong, then you just simply close the eye with the palpebral part. If the light is very strong, then you strongly close your eyes with the orbital part. And in the last few minutes, I just like to touch some clinical conditions. These are interesting clinical relations. These won't be asked in the exam. Only the facial nerve palsy that I mentioned is going to be asked in detail. I just want you to see that even later these positions where the pathways and the nuclei are can be very important, because depending on which part of the brainstem is lesioned will determine the symptoms. So here you can see, for example, the medial medullary syndrome, which you will learn in neurology. You know which tracts or nuclei are in the medial part of the medulla, hypoglossal nucleus, medial lemniscus, and the pyramids, and this determines the symptoms of the patient, or the lateral medullary symptom, syndrome or Wallenberg syndrome, when the lateral part of the medulla is lesioned because of a posterior inferior cerebral artery thrombosis. And for example, so in this part of the medulla we have many pathways and nuclei, and this explains why we have this combination of these symptoms. Or locked-in syndrome, which now, studying the pathways going through the brainstem, you can understand that the sensory pathways at the level of the pons are completely separated from the motor pathways, from the pyramidal tract. So there can be a lesion, a level of the lesion, when the motor tracts are all damaged, the sensory tracts are intact. And if it happens in the pons, then only the oculomotor and trochlear nerves are going to be intact, which are positioned in the mesencephalon. So basically these patients are conscious, they feel everything, so pain also, but cannot move anything except for the eye. So this is why it's called locked in, because they are kind of locked in their own body. And also a horrible disease is ALS, or amiotrophic lateral sclerosis, which affects the motor neurons in the spinal cord and in the brainstem. So basically these patients are not able to move anything, and it's usually ascending, so they can, just like in the case of Stephen Hawking, he could still move his eyes, which is in the uppermost part of the brainstem. With this, I would like to thank you for the attention.